I want you to just try to picture a scenario for a second. I want you to fully visualize this physical environment. So you are standing on the sidelines of a local sports court.
Okay.
It's a crisp evening. And you are watching a 19-year-old netball player. Yes, a 19-year-old.
Right, young athlete.
Exactly. She is in the middle of this high-stakes match, and she is running at full tilt down the court. She leaps up for an interception, eyes entirely focused on the ball, extending her body through the air, and then, gravity takes over and she lands.
And I'm guessing the landing isn't clean.
No, the landing isn't clean at all. She lands, her foot plants firmly, basically locking her cleats into the intense friction of the court, and she twists her upper body forcefully to pass the ball.
Oh, wow.
Yeah, in that microsecond beneath the skin of her knee, extreme biomechanical forces are just at play. The massive torque of her femur rotating against her fixed tibia creates this impossible vector of force.
It's a recipe for disaster.
It really is. Her kneecap, the patella, is violently derailed. It dislocates laterally. I mean, it is pushed completely out of its groove to the far outside edge of her knee.
Right.
So she goes down, screaming in agony, clutching her leg. But here is the bizarre, deeply unsettling part of this scenario. As she lies there on the pitch, trying to compose herself, her brain sends a reflex signal.
Ah, I know where this is going.
Yeah, she instinctively straightens her leg, she extends the knee, and as she does, with this sickening audible clunk that you can literally hear from the sidelines, the kneecap relocates. It snaps right back into the center of the joint.
Oh, man. It is an incredibly vivid, incredibly painful image to visualize. And unfortunately, it's one that emergency rooms, sports clinics, and orthopedic wards see with alarming regularity.
I bet.
Yeah, that audible clunk is the sound of bone finding its way back home, but at a massive structural cost. It is the absolute classic presentation of an acute lateral patellar dislocation.
Well, I want to pull this apart immediately because I want to put myself in the shoes of the clinician who was seeing her in the clinic a few days later.
Absolutely.
To truly understand why this happens, we are looking at a massive stack of source material for this deep dive today. Surgical notes, deep anatomical mapping studies, and decades of orthopedic literature that break down the precarious anatomy of the knee.
It's a lot to unpack.
It is. We are essentially mapping out a biomechanical ecosystem here. So I am looking at this 19-year-old patient, a 19-year-old. I order an MRI.
Right, you want to see the damage.
Exactly. I want to see the physical damage caused by that horrifying twist. What exactly does her MRI show?
Well, when you pull up the fluid-sensitive sequences on that MRI, you're looking for the bright white signals of edema and injury against the darker background of normal tissue, right?
Right.
And in this specific injury, you're going to see a highly specific, very predictable pattern of bony injury. You will see a severe bone bruise on the lateral femoral condyle.
The lateral femoral condyle, so that's the outer knuckle of the thigh bone?
Exactly, the outer knuckle. And you will also see a chondral injury, a distinct cartilage defect on the medial facet of the patella. That's the inner half of the kneecap.
Okay, I am looking at this theoretical imaging in my mind, and I am frankly incredibly confused on behalf of the listener because the geometry just doesn't seem to add up.
How so?
Well, let's think about this logically based on the vectors we just described. The knee twisted, the patella went laterally, it derailed to the outside.
Correct.
So if the bone flew off to the lateral side, why on earth is the crushing damage on the medial side of the kneecap?
It's a great question.
Right. Shouldn't the lateral outer edge of the patella be the part that gets smashed as it flies off the tracks?
It is the single most common, perfectly plausible, wrong assumption that almost every young surgical candidate makes when they first start looking at these scans.
Oh, really?
Oh, yeah. And the reason it is so confusing is because human intuition naturally focuses on the traumatic exit. You are picturing the wrong half of the chronological event.
It's a wrong half.
Yes. You are focusing entirely on the dislocation, the bone violently leaving the station. To understand the MRI, I want you to ask yourself what the medial facet of the patella actually hits, and crucially, when it hits it.
Okay, let me try to completely reimagine the physics here in ultra slow motion.
Go for it.
So the moment of injury, it's dislocated. The patella is sitting entirely out on the lateral side of the knee joint. It's completely derailed, sitting on the outside of the femur.
Right.
Then she straightens her leg on the pitch. The massive muscles of the front of the thigh, the quadriceps, they fire.
Yeah.
They contract with immense force to extend the leg. And because they are tethered directly to the patella, they pull it. and it snaps back into the groove.
Exactly. Now freeze that frame in your mind.
Okay, frozen.
The patella is accelerating from the far outside of the knee, rushing back toward the center of the joint under the immense tension of the quadriceps.
Yay.
As it travels laterally to medially, what bony structure does it have to cross on the way back in?
Oh, I see. It has to cross the outer cliff edge of the groove. It crosses the lateral femoral condyle.
Yes.
So because it's moving from outside to inside, the medial edge, the inner edge of the patella, is actually the leading edge of the bone as it travels back inward.
Exactly right.
It brutally scrapes and impacts over the lateral femoral condyle as it relocates.
Precisely. The medial patellar facet strikes the lateral femoral condyle during the violent relocation. 2 bruises, 2 distinct surfaces, 1 violent collision.
Wow.
The clinical insight here, the fundamental principle you have to internalize before we go any further in this deep dive, is that the crushing bony injury is caused by the reduction, not the dislocation.
The reduction.
Yes. The devastating structural damage happens on the way back in, not the way out.
That completely shifts the paradigm of how I view this injury. I mean, the sheer force of the body trying to fix itself, trying to pull the bone back to center, is what shears the cartilage off. 2 surfaces, 1 collision.
It is arguably the most elegant mechanical lesson in the entire knee, and it opens the mission for our entire deep dive today perfectly.
Yeah, I think it does.
Because absolutely everything in the patellofemoral joint, every pathology, every anatomical quirk, every millimeter precise surgery we're going to explore it, is all about a bone being dragged across a groove it fundamentally does not want to stay in.
Right. And if the bone doesn't want to stay in the groove, well, we need to understand the physical architecture of that groove and exactly when the bone is most at risk of slipping out.
Exactly.
If this is a train on a track, we basically need to know when the wheels actually touch the steel.
Spot on. We need to look at the tracking geometry. The trochlea, which is the anatomical groove on the front of the femur, is not uniformly deep. It's not a perfect half pipe.
Right, it changes shape.
At the very top, superiorly, it is quite shallow, almost completely flat in some people. But as you trace it downwards, as you bend the knee further, the groove gets significantly deeper and the bony walls gets deeper.
Okay, so what's the threshold?
That's the first crucial mechanical threshold we must establish. And it is a number you must absolutely bank in your memory. At what exact degree of knee flexion does the patella center itself and become captured in the trochlear groove?
Well, if I am sitting for my exams, I know the options usually range in 5-degree increments. 0 to 5, 5 to 10, 10 to 15, 15 to 20, 25 to 30.
Yep, the classic multiple choice spread.
And the definitive, universally accepted answer is 15 to 20 degrees. 15 to 20 degrees.
15 to 20 degrees. Yes, 15 to 20 degrees. That is the exact mathematical window of engagement.
I really want to expand heavily on what this actually means for our understanding of human anatomy, because that number implies something deeply unsettling about the rest of the knee's range of motion.
It really does.
Let's visualize a human leg perfectly straight, locked out in full extension. That is exactly 0 degrees. 0 degrees.
Right.
Between 0 degrees and 15 degrees of flexion, what is physically happening to the kneecap?
At full extension, at perfectly 0 degrees, the patella is sitting above the true groove. It is entirely unsupported by the bony architecture of the femur.
It's just floating.
It is essentially floating in anatomical space.
Yeah.
I mean, if you sit with your leg perfectly straight and your quadriceps completely relaxed right now, you could take your thumb and index finger and physically wiggle your kneecap side to side.
Yeah, you totally can.
It translates freely across the front of your knee because there is no bony constraint holding it back.
Right.
Between 0 and 15 degrees, it is held in place by absolutely nothing but soft tissue.
Wow.
It isn't until you bend the knee, flexing it past 15 degrees, that the patella physically slides down and is deeply captured by the bony walls of the trochlear groove.
That 15 degrees is a terrifyingly fragile window.
Yes, 15 degrees.
It is. Between 0 and 15 degrees, you are relying entirely on ligaments and muscle tissue to prevent a dislocation.
Entirely.
So if the bone is completely unsupported by the groove in early flexion, how does this 15 to 20 degree rule fundamentally alter how we medically image the knee?
That is the key clinical application.
Like, if I suspect a patient has subtle tracking instability and I send them to the MRI scanner, how does this geometric reality dictate my imaging order?
It completely dictates your order. And honestly, getting it wrong is a massive clinical failure. Let's talk about axial MRI views.
Those are the cross-sectional imaging slices.
Exactly. The ones that look top down through the kneecap and the groove, like looking down into a canyon. Axial views taken beyond 20 degrees of flexion are utterly useless for detecting subtle patellar instability.
Beyond 20 degrees.
Beyond 20 degrees. If the knee is bent beyond 20 degrees while they are lying inside the scanner tube, the bone is already deeply captured by the trochlea.
Oh, because the groove forces it into place.
Exactly. The deep bony geometry mechanically forces the patella into the dead center of the joint. You could have a patient with massively incompetent, entirely shredded ligaments, but if you scan them at 30 degrees, the MRI will show a perfectly centered patella.
Because the groove itself is doing all the work.
Precisely. To actually see the instability, to see the patella drifting off center, you have to image the knee in early flexion before the bone is captured.
Okay, let me say it back to you. Let me synthesize this to make sure my mental model is perfectly accurate before we move on.
Go ahead.
The patella is completely unsupported by bone until 15 degrees. It is hovering, floating on a web of soft tissue. After 20 degrees, it's deeply captured by the groove.
Right.
Therefore, both the violent dislocation event we described at the start, the moment it slips off the tracks, and the medical imaging required to accurately detect that subtle instability must happen in that fragile first 15 degrees.
That is the perfect synthesis. The pathology and the diagnosis share the exact same geometric window.
So if you want the absolute distilled essence of the one-liner to commit to memory.
The patella centers in the trochlea at 15 to 20 degrees. So everything below that is held by soft tissue, and axial imaging beyond 20 degrees hides instability.
So if the bone is hovering in space for those first 15 degrees without any bony walls to guide it, what is physically keeping it from sliding off the side of the knee?
Soft tissue.
Right, we know soft tissue is doing all the heavy lifting below 15 degrees, but we need to meticulously dissect the most critical piece of that soft tissue. What is the actual tether?
We are talking about the primary safeguard of the patellofemoral joint, the medial patellofemoral ligament, universally referred to as the MPFL.
The MPFL.
Yes. The core anatomical fact here is that the MPFL is the most important passive stabilizer against lateral dislocation.
Let me pause on that specific terminology because the word passive is doing a massive amount of heavy lifting in that sentence.
It is.
Passive means ligament, right? It's a static tether, a biological rope that only engages when stretched. Dynamic means muscle, an active contractile pulling force.
Exactly.
So the vastus medialis obliquus, the VMO muscle on the inner thigh, is the primary dynamic stabilizer. It actively pulls, but the MPFL is the primary passive one.
That is exactly right. Passive is ligament, dynamic is muscle. Both are critically true for knee function. You just have to know which biological system of stability you are analyzing.
Makes sense.
Now, the MPFL is a distinct band of tissue that runs from the inside aspect of the femur over to the upper inner border of the patella. And there's a mind-boggling biomechanical number attached to its tensile strength.
Hit me with it.
The MPFL contributes exactly 50 to 60% of the total restraining force against lateral displacement.
Let me repeat that because the physics of it are genuinely insane. 50 to 60%. 50 to 60% of the entire restraining force keeping the kneecap aligned comes from one single, relatively thin ligament.
It is an incredible biomechanical bottleneck. More than half the entire physical load of keeping that bone from flying out of your leg during a pivoting jump rests on a fibrous structure that is only a few centimeters long.
That's a huge burden.
It is. And this immense concentration of force is exactly why the MPFL fails in almost every single first-time dislocation. If the patella dislocates laterally, you have, by mathematical definition, overpowered the MPFL.
Right.
It has torn, ruptured, or plastically stretched entirely beyond function.
So if it fails that reliably, surgeons obviously have to go in and reconstruct it. And if we are going to fix it, we have to know exactly where it lives in the three-dimensional space of the leg.
You do.
Let's do a virtual dissection for the listener. We need to cut through the skin and look at the highly specific anatomical layers of the medial side of the knee. What layer does the MPFL actually live in?
Well, the medial side of a knee is described anatomically in three distinct layers. Think of them like overlapping sheets of a Kevlar vest where each layer serves a different structural purpose.
Okay, 3 layers.
The MPFL lives specifically in the second medial layer of the knee, the second medial layer.
Walk me through this spatial visualization. I'm the surgeon. I have a scalpel. I am making an incision on the inside of the knee. What am I cutting through sequentially?
You make your skin incision, you dissect down to the subcutaneous fat. The very first structural layer you hit is layer 1.
Layer 1.
Layer 1 consists of the deep investing fascia of the leg, the sartorius muscle fascia, and the superficial medial retinaculum, layer 1. It's the outermost enveloping sleeve that wraps the entire inner knee.
Right, so I carefully take my scalpel, slice vertically through layer 1, and I peel it back like opening a jacket. What am I looking at underneath?
Now you're looking directly at layer 2. The
Yeah.
second layer, this is where the heavy, distinct structural ligaments live.
Okay, what's in there?
Layer 2 contains the superficial medial collateral ligament, the prominent MCL, the posterior oblique ligament, the tendinous expansions of the semimembranosus, and right there, blending into the underside of layer 1, is our MPFL. Layer 2 is its definitive home.
And just to complete the mental map, if I were to keep going and cut aggressively through layer 2,
You would immediately hit layer 3.
layer 3.
The third layer, which is comprised of the deep MCL and the actual true joint capsule. If you cut through layer 3, the third layer, you have breached the joint space. You are inside the knee, looking directly at the synovial fluid and the articular cartilage.
Okay, so we know the MPFL is sandwiched in layer 2. Why is knowing its exact zip code in the second medial layer so surgically relevant?
Because when a surgeon goes in to reconstruct a destroyed MPFL, they don't just sew the shredded ends back together.
Right, they need a graft.
Exactly. They take a piece of donor tendon, usually a strip harvested from the patient's own hamstring, and they have to route it through the tissue to recreate the ligament.
Ah.
To do it anatomically and biomechanically correctly, reconstructions must carefully pass the new tendon graft exactly between layer 1 and layer 2.
Between layer 1 and layer 2.
Yes, if you pass the graft outside of layer 1, it sits immediately under the skin, it's cosmetically ugly, it can tether to the scar, and the pulling mechanics are entirely wrong.
Makes sense.
But if you pass it deep to layer 3, you've accidentally routed the graft through the inside of the joint where it will grind against the cartilage. It absolutely has to glide smoothly the natural fascial plane between layers 1 and 2.
That requires immense spatial awareness.
Yeah.
But here is where this topic gets highly controversial and honestly a bit dramatic in the academic world.
Oh, yes, it does.
Let's talk about where this ligament actually anchors to the thigh bone. The femoral attachment controversy. There is a notoriously broken textbook and exam question about this exact location that drives surgical candidates insane, isn't there?
It is legendary for how fundamentally broken it is. The standard exam question asks candidates to identify the exact anatomical location of the femoral tunnel for an MPFL reconstruction. Where do you drill the hole in the femur to anchor the new graft?
Seems like a straightforward question.
You would think so. The problem is, the exam options provided in historical test banks are mathematically impossible to choose from based on real anatomy. Two of the options are sometimes word for word identical.
You're kidding.
No. And to make it infinitely worse, the textbook explanation provided for the correct answer directly contradicts its own cited research.
I love when high-level academia trips over its own shoelaces. So what does the cited research paper actually state?
The explanation cites a highly famous, incredibly meticulous anatomical mapping paper by a surgeon named Schottle.
Schottle.
Schottle mapped this femoral attachment out beautifully using cadavers and radiography. His precise anatomical description states that the central origin of the MPFL lies approximately 1.9 millimeters anterior and 3.8 millimeters distal to the adductor tubercle.
1.9 millimeters anterior and 3.8 millimeters distal.
Exactly. Yet the textbook concludes the answer is proximal and posterior. It literally cites Schottle's numbers for distal and anterior, and then tells the student the answer is proximal and posterior. It's a complete typographical and conceptual failure.
That is completely absurd. The explanation contradicts its own citation. So we are going to throw the broken textbook question in the trash right now and establish the absolute true anatomy for the listener.
Nicole.
If I am the surgeon in the operating room, with my gloved finger inside the incision, physically palpating the contour of the femur, where exactly is the true biological origin?
Feel the inner bony contour of the distal femur. You will feel a prominent bump called the adductor tubercle, which is where the massive adductor muscles of the inner thigh attach.
Okay, got the bump.
Just below that, there is another bony bump called the medial epicondyle. The true femoral origin of the MPFL sits right in the bony saddle between the adductor tubercle and the medial epicondyle.
In the saddle.
Specifically, it is located distal to the adductor tubercle and just anterior to it. Distal and slightly anterior.
Distal and just anterior. Now, feeling it with a finger is one thing. It relies on tactile feedback. But surgeons need absolute objective proof before they drill an irrevocable hole in a patient's bone.
Right.
So we use an X-ray in the operating room. We use a highly specific radiographic landmark.
Yes, tactile feedback isn't enough when millimeters dictate success or failure. This is where we bring in Shuttle's point.
Shuttle's point.
Shuttle's point is defined on a true lateral radiograph, a perfect non-rotated side view X-ray of the knee on the operating monitor. To find it, you have to draw a grid of lines on the screen.
Walk me through the grid.
First, you draw a line straight down the posterior femoral cortex, the straight back wall of the femur bone. Then you draw a second line representing the posterior origin of the medial femoral condyle, where the curve of the knuckle begins.
Okay, 2 lines.
And finally, you draw a third line called Blumensatz's line, which represents the dense bony roof of the intercondylar notch where the ACL lives. Where these 3 lines intersect in a very specific, reproducible geometric relationship, that exact coordinate is Shuttle's point.
So we have 2 completely different languages describing the exact same physical coordinate in space. We have the anatomical tactile language distal and anterior to the adductor tubercle, and the radiographic language using intersecting lines on an X-ray screen.
Exactly.
Why does hitting this exact coordinate matter so much? Why are we arguing over millimeters? 1.9 millimeters here, 3.8 millimeters there. Does a single millimeter really matter that much to the patient's outcome?
This raises the most important biomechanical question of the entire procedure, and it brings us to the unforgiving concept of isometry.
Isometry.
The MPFL is a unique structure because it is an almost perfectly isometric ligament. That means as the knee continuously bends from 0 to 90 degrees, the distance between its attachment point on the femur and its attachment point on the patella stays essentially exactly the same.
It doesn't change length.
No, it doesn't stretch out and it doesn't go slack. It maintains a state of perfect constant tension throughout the arc of motion.
Like a perfectly placed door hinge. If the hinges are perfectly aligned on the frame, the door swings smoothly without binding or dropping.
That is the exact mechanical equivalent. But if a surgeon drills that femoral tunnel off by just a few millimeters away from Shuttle's point, the graft completely loses its isometry.
Oh, wow.
If the tunnel is placed too proximal, if they drill the hole too high up the femur, the graft will get brutally tight as the knee bends into flexion. It will act like a rigid tightrope, violently pulling the kneecap backward into the groove, overloading the medial facet cartilage, causing severe crushing pain, and physically preventing the patient from bending their knee past a few degrees.
That sounds horrific. And what if they overcompensate and drill it too distal, too far down the femur?
If the tunnel is placed too distal, the opposite mechanical failure occurs. The graft becomes incredibly tight when the leg is straight in full extension, but as soon as the knee bends, the distance between the 2 points physically shortens and the graft goes completely loose and floppy.
It just gives out.
It goes entirely slack exactly when you need it to be, providing that critical 50 to 60% restraining force we talked about. A few millimeters either way, and the reconstruction utterly fails.
That's terrifying.
The graft will either snap from massive overtension or the patient will simply dislocate their kneecap again because the graft is too loose to hold it.
That is surgical precision with zero margin for anatomical error. Millimeters separate a cured patient from a lifelong disability. If you want the distilled essence of this entire ligament,
the MPFL is the primary passive restraint at 50 to 60% of the restraining force. It lives in the second medial layer, and its femoral origin is distal and just anterior to the adductor tubercle. Get that within millimeters or the graft fails.
we know how the ligament fails mechanically, we know the exact layers it lives in, and we know how to replace it. But what happens immediately after the trauma we described in the cold open, and more importantly, what does the statistical future hold for this patient?
Let's bring our clinical focus back to our 19-year-old netball player. Following her acute lateral dislocation on the court, we sent her for the MRI. We briefly touched on the bony collisions, but there is a formal MRI triad you must immediately recognize when reading the scan.
The triad.
An acute lateral patellar dislocation reliably produces 3 specific findings. 1, an osteochondral defect, a gouge of cartilage and bone off the medial patellar facet.
Yep.
2, a profound contusion, a bone bruise of the lateral femoral condyle. 3, an MPFL disruption.
I want to highlight a massive clinical trap for young surgeons and physicians evaluating these scans. It is overwhelmingly tempting to assume the lateral facet of the patella is the damaged side,
It really is.
because intuitively it's the side that's obviously exposed, it's the side sitting entirely outside the joint during the dislocation, and it feels like it should be the leading edge of the trauma.
It is the ultimate conceptual trap. I must remind the listener, as we meticulously established in the beginning, the medial facet is what takes the catastrophic hit.
Right.
The medial facet takes the hit during the violent relocation event. It smashes violently into the lateral femoral condyle as the quadriceps snap the bone back into place.
Okay, so we read the scan. She has the classic triad: medial facet cartilage damage, lateral condyle bone bruise, entirely torn MPFL. We put her in a stabilizing brace. We give her crutches. We send her to intense physical therapy to strengthen the dynamic stabilizers like the VMO.
Standard protocol.
But what happens if this is treated non-operatively? We don't reconstruct the MPFL. What is her statistical destiny?
The statistical risk of redislocation, if treated non-operatively, is a highly sobering reality. The redislocation rate is 15 to 45%. 15 to 45%.
That is a massive, highly variable range, 15 to 45%. Almost half of these patients might dislocate again just walking down the stairs.
Yes.
Why is it such a wide range? And what specific anatomical factors push a patient all the way up to that severe 45% mark?
The wide range exists because every single patient's underlying skeletal anatomy is entirely different. The risk factors that push a patient to the extreme 45% mark are deeply genetic and anatomical.
Like what?
We are talking about young age, skeletal immaturity, trochlear dysplasia, which means the groove on their femur was genetically formed too shallow or entirely flat from birth, patella alta, meaning their kneecap naturally sits abnormally high up the thigh bone, and crucially, an increased tibial tubercle to trochlear groove distance.
Let's deeply unpack that last metric, the TTTG distance. The tibial tubercle is the prominent bony bump on your shin where the powerful patellar tendon ultimately attaches.
Right.
The trochlear groove is the channel where the kneecap is supposed to ride. If we superimpose these two structures on a CT scan, and we see that the tubercle on the shin is located too far laterally, too far to the outside of the leg compared to the center of the groove above it, the massive quadriceps muscle is constantly pulling the kneecap outward at a harsh oblique angle.
Exactly.
It's actively pulling the train off the tracks every time they take a step.
Exactly. It creates a lateralized vector of force. The muscle isn't pulling straight up, it's pulling up and out.
Let me say it back. Roughly 1 in 5 to nearly half of first-time dislocators will suffer the exact same trauma again, 15 to 45%.
Yes.
And the patients who do redislocate are the ones who are young, skeletally immature, and have fundamentally dysplastic anatomy. They have genetically shallow grooves, high-riding kneecaps, and laterally deviated pulling vectors.
And here is the overarching philosophical framing of this entire pathology. The traumatic dislocation event on the netball court merely revealed the anatomic problem. It didn't create it.
It revealed it.
The shallow groove was sitting there before she ever jumped. The high kneecap was there before she landed. The anatomy was a loaded mechanical gun, and the twisting maneuver on the court was just the final trigger.
The dislocation revealed the anatomy. It didn't create it. That completely reframes how we should view the patient walking into the clinic. Give us the distilled summary.
The triad is a medial patellar facet chondral injury, a lateral femoral condyle bruise, and a torn MPFL, and 50 to 45% will do it again because the anatomy that let it happen is still there.
We are going to lock in the precise numbers, layers, and percentages we've just established. I'll tee up the concept, you knock down the absolute gold standard facts, tracking geometry.
The patella definitively engages the trochlea at exactly 15 to 20 degrees. Below 15 degrees, it is held by soft tissue alone, and axial imaging past 20 degrees entirely misses subtle instability because the bone is captured.
MPFL biomechanics.
It is a primary passive restraint. It provides 50 to 60% of the restraining force. It lives securely the second medial layer, deep to the retinaculum of layer 1. Its exact femoral origin is distal and just anterior to the adductor tubercle, sitting in the saddle just before the medial epicondyle.
Dislocation and recurrence.
The imaging triad is a medial patellar facet chondral injury, a lateral femoral condyle bruise, and an MPFL tear. The chondral damage is caused by the relocation, not the dislocation. Redislocation occurs in 15 to 45% of cases, made dramatically worse by youth, skeletal immaturity, trochlear dysplasia, patella alta, and an increased TTGD distance.
So If we've established that underlying dysplastic structural anatomy is what causes the constant redislocation, how does a surgeon actually fix the hard architecture of the bone? I mean, we can't just easily carve a new, deeper groove into the femur without destroying the joint surface.
No, we can't.
But we can physically move the anatomical attachment points.
Exactly. We can't easily change the track, but we can profoundly change the vectors of force pulling the train. And that brings us to one of the most mechanically genius, pure engineering procedures in all of orthopedics. The Fulkerson osteotomy, formerly known in the literature as an anteromedialisation of the tibial tubercle.
Break down the etymology and physics of that word for me. Anteromedialisation. Anterior, meaning shifting forward in space. Medial, meaning shifting inward toward the midline of the body.
Yes.
We are literally taking a surgical bone saw, cutting the entire bony bump off the front of the shin bone and moving it forward and inward.
Yes. The surgeon uses a sagittal saw to make a highly specific angled sloped cut beneath the tibial tubercle on the shin. By sliding the freed piece of bone with the patellar tendon still firmly attached to it up this precise sloped cut, the tubercle is shifted mechanically in two geometric directions simultaneously.
Forward and inward.
Exactly. It moves anteriorly, protruding further out and proud from the shin, and it moves medially, translating toward the inside of the leg. Then the surgeon secures it back down into its new position using heavy lag screws.
I want to really visualize the physics of this load transfer because this is pure, unadulterated lever arm mechanics. Let's look at the medial shift first. If I detach the bony attachment point and move it medially inward, I am fundamentally changing the angle of the patellar tendon.
You are.
The quadriceps are no longer pulling the patella harshly toward the outside of the knee. I am mathematically shifting the immense compressive load off the lateral facet of the patella and transferring that load onto the medial facet.
You are exactly right. That is the mechanical purpose of the medial shift. You are correcting the lateralized vector. Now, what does the anterior shift accomplish? If I move the bony attachment point forward, lifting it proud off the front of the shin bone.
Well, if I move it anteriorly, I am lifting the entire tendon away from the joint line. I am essentially tilting the kneecap like a lever.
Correct.
I am shifting the compressive load off the distal part of the patella, the bottom half near the tendon, and transferring it onto the proximal part, the top half. Because as the knee bends, the natural contact point on the back of the patella rolls from the bottom to the top.
Exactly.
So by lifting the tendon forward, I drastically reduce the mechanical pressure on the bottom half.
This spatial reasoning is absolutely flawless. And this precise understanding of vectors dictates exactly when you are medically allowed to perform this operation. Because of this highly specific load transfer, the Fulkerson osteotomy is perfectly uniquely suited for patients who have focal cartilage damage chondral lesions on their distal and lateral patella. Distal and lateral patellar chondral lesions.
But the laws of physics dictate that every surgical action has an equal and opposite reaction.
Always.
If I am intentionally moving the load off the distal and lateral sides of the kneecap, I am necessarily transferring immense, concentrated physical load on NTO, the proximal and medial sides of the kneecap.
Precisely. Which means this operation is strictly, absolutely contraindicated for patients who already have proximal, medial, or diffuse patellar arthrosis.
Ah, of course.
If a patient has a massive cartilage crater or exposed bone on the medial facet of their kneecap and you perform an anteromedialisation, you are taking the full, immense force of the quadriceps muscle and focusing it directly like a laser onto that damaged medial cartilage crater. You will completely destroy their joint and cause agonizing, unremitting pain.
So it is absolutely contraindicated for proximal, medial, or diffuse lesions. It is only designed for distal and lateral lesions. There is a massive clinical trap here that catches out half the candidates on the oral boards.
There is. I must warn the listener, the trap is thinking of the Fulkerson osteotomy solely as a stability operation to stop dislocations.
Right.
Yes, moving the tubercle medially reduces that dangerous TT-TG distance we talked about, which helps stop the kneecap from dislocating. But in the context of chondral lesions and joint wear, this is fundamentally an operation about load transfer. It is about actively moving the pressure off a biological pothole and onto smooth, healthy cartilage pavement.
We are mechanically shifting the burden to save the joint. Give us the distilled summary.
Anteromedialisation unloads the distal and lateral patella, so it's for distal and lateral lesions, and it's contraindicated in proximal, medial, and diffuse disease.
Okay, so we've talked extensively about fixing natural biological joints, shifting natural bone, and altering native force vectors. But what happens to the tracking ecosystem when humans intervene and install artificial metal and plastic components when a patient undergoes a total knee replacement?
This is where surgical geometry gets incredibly unforgiving. When we replace a knee, we use saws to cut off the arthritic ends of the femur and tibia, and we cement on highly engineered metal caps. The problem is, the patellofemoral joint does not respect the artificial boundary between the knee cap and the main hinge of the joint. Everything is physically connected by the extensor mechanism.
It's all one system.
Exactly. The absolute biggest, most catastrophic tracking problems in total knee replacements are caused by how the surgeon rotates these metal components in three-dimensional space before the cement hardens.
Let's pose a spatial puzzle to figure this out. What is the actual mechanical consequence of internally rotating the tibial component during a total knee replacement?
Let's walk through the spatial reasoning step by step. The tibial component is the flat metal tray sitting on top of the cut shin bone.
Okay, visualizing the tray.
The tibial tubercle, that bony bump where the patellar tendon firmly attaches, is part of the native shin bone itself. It sits just a few inches below this metal tray. Now, imagine you are looking straight down at the top of the cut shin bone. If the surgeon glues the metal tray on, but accidentally rotates it, internally twists it inward toward the patient's other leg, what happens to the relative position of the native tubercle compared to the new center of the metal tray?
Okay, visualizing the geometry. If the tray rotates internally, the center of the tray moves inward. Relative to that new inward center, the attached bony tubercle is effectively left behind on the outside.
Exactly.
The tubercle is pushed laterally relative to the new mechanical axis of the tray.
Exactly. An internally rotated tibial tray effectively lateralizes the tibial tubercle. And we know exactly what lateralizing the tubercle does from our previous discussion. It drastically increases the Q angle.
The Q angle. The geometric angle between the upward pull of the quadriceps muscle from the thigh and the downward line from the patella to the tubercle. It's essentially a bowstringing effect. If the tubercle is lateralized, that Q angle increases. It gets wider and more acute. A higher Q angle acts exactly like pulling a bowstring sideways. It drives brutal lateral patellar tracking. The kneecap gets pulled hard to the outside of the artificial joint.
It does.
It causes subluxation, severe grinding, and massive shear stress on the plastic polyethylene components.
It's a complete biomechanical disaster. And the exact same disaster happens if the femoral component, the large metal cap on the thigh bone, is internally rotated or medially translated during the bone cuts. Any internal rotation of either major component increases the Q angle and completely ruins the tracking of the kneecap.
So what's the rule?
This gives us the golden, unbreakable rule of thumb in total knee arthroplasty. When in doubt, externally rotate. External rotation decreases the Q angle and normalizes the tracking.
Externally rotate. I have that locked in. Now, what about the patellar component itself? During knee replacement, surgeons often shave off the arthritic back of the kneecap and cement a smooth plastic dome onto it called a patellar button.
The spatial positioning of that plastic dome on the cut bone is highly critical. Lateral placement of the patellar button is the absolute worst tracking error a surgeon can make on the kneecap itself.
The worst.
Yes. If you cement that dome too far to the outside lateral edge of the kneecap, you are effectively tightening the lateral tissues and forcing the joint to track poorly against the metal femur. Conversely, medialization of the button, intentionally placing it slightly toward the inside edge of the native bone, is inherently safe and actively improves tracking.
Medial is safe, lateral is a disaster.
Exactly.
Sometimes, even if a surgeon achieves perfect component rotation, the kneecap still wants to physically tilt laterally because the biological tissues on the outside of the knee, the lateral retinaculum, are just naturally too tight and contracted.
That happens, yes.
So a surgeon might perform a lateral release. They take an electric cautery scalpel and literally cut the tight lateral tissues from the inside out to let the kneecap sit flat in the groove. But there is a massive, highly dangerous hidden pitfall here involving the blood supply to the bone.
There is, and it can cost the patient their entire extensor mechanism. During a lateral retinacular release, a very specific fragile blood vessel must be identified and preserved at all absolute costs.
Which one?
The superior lateral genicular artery. The superior lateral genicular artery.
That feels like a piece of anatomical trivia suddenly becoming violently relevant. We map these vessels in medical school, but this is where the theory hits the operating room reality, isn't it?
This is exactly where anatomical theory dictates catastrophic outcomes. The patella has an incredibly fragile, tenuous blood supply. The superior lateral genicular artery runs transversely, straight across the anatomy, just proximal to the lateral femoral condyle. It is hiding right in the exact tissue plane where the surgeon is blindly making their deep cut for the lateral release.
What are the dire physical consequences if a surgeon's scalpel accidentally cuts this specific artery?
The consequences are utterly devastating. If you cut that superior lateral genicular artery, you are instantly shutting off a massive portion of the arterial blood supply to the top half of the kneecap.
Oh, wow.
Now, a healthy, intact native knee might actually survive that single insult due to collateral flow. But remember the context. This is a total knee replacement. The surgeon has already used a power saw to aggressively shave off the back of the patella to place the plastic button, which completely destroys the intraosseous blood vessels inside the bone.
Right, the internal blood supply is gone.
Furthermore, they have likely stripped out the Hoffa's fat pad at the front of the knee to see the tibia better, which completely destroys the inferior blood vessels feeding the bottom of the bone.
Oh, wow. The biological insults stack up, so the risk is entirely cumulative.
The risk is massively, dangerously cumulative. Resurfacing the bone with a saw, plus stripping the fat pad for visibility, plus accidentally cutting the superior lateral genicular artery during the release.
That's 3 strikes.
You combine those 3 vascular insults, and you induce complete patellar osteonecrosis. The bone of the kneecap literally starves of oxygen, undergoes a vascular necrosis, and dies. It becomes brittle and crumbles into fragments inside the patient's leg under the stress of walking. It is a catastrophic complication that requires incredibly complex revision surgery.
Let me say it back and synthesize these mechanical and vascular rules to lock them in. Internal rotation of the tibial component lateralizes the native tubercle. That increases the Q angle, pulling the patella laterally like a bowstring.
Correct.
Internal rotation of the femoral component does the exact same thing. Internal rotation equals lateral trapping disaster.
That is exactly correct, which leads to the distilled essence for this entire segment. Internally rotating either component lateralizes the tubercle and raises the Q angle, medialize the patellar button, never lateralize it, and absolutely preserve the superior lateral genicular artery in any lateral release.
We are going to rapid-fire trade the facts from the realignment and arthroplasty sections to cement them. I'll start. Anteromedialisation of the tibial tubercle mathematically unloads the distal and lateral patella, so it is perfectly specifically indicated for distal and lateral chondral lesions.
And it is strictly fundamentally contraindicated in proximal, medial, and diffuse disease because it would transfer immense destructive load directly onto the already damaged cartilage.
Component rotation in arthroplasty. Internal rotation of the tibial component lateralizes the tubercle, increasing the Q angle. Internal rotation or medialization of the femoral component does the exact same disastrous thing.
Lateral placement of the plastic patellar button is the worst tracking error on the bone itself. Medializing it is safe. And you must preserve the superior lateral genicular artery during any lateral release to prevent the cumulative vascular insult of patellar osteonecrosis.
So we have thoroughly covered the solid bone, the geometry of the groove, the static ligaments, and the artificial metal components. Now we need to look at the vital dynamic connective tissues anchored to either end of the patella.
The actual tendons.
Yeah, the tendons that generate the mechanical movement of the leg.
The massive biological cables and pulleys of the extensor mechanism. Let's start with a highly classic clinical presentation. A 22-year-old basketball player walks into your clinic. 22 years old.
Okay, 22-year-old.
He has had 6 straight weeks of debilitating anterior knee pain. 6 weeks. It gets intensely, sharply worse with explosive jumping or bounding. You take x-rays, and the bones are perfectly normal. We are looking at the classic presentation of jumper's knee or patellar tendinopathy.
The diagnostic key to distinguishing this from a dozen other knee complaints is the exact pinpoint location of the pain. Where exactly does it hurt when you palpate the knee?
The point tenderness is located exactly at the inferior pole of the patella. Yeah. The inferior pole. That is the very bottom V-shaped tip of the kneecap, which serves as the proximal bony insertion point of the patellar tendon.
And mapping this specific anatomy matters immensely because if the intense pain was at the other end of the tendon down at the tibial tubercle on the shin bone, and the patient was significantly younger, say a 14-year-old going through a growth spurt, that would be a completely different disease process, right?
Exactly right. Pain localized at the tibial tubercle in a skeletally immature adolescent is Osgood-Schlatter disease, which is a mechanical traction apophysitis and irritation of the open growth plate.
But our guy is 22.
Right. Our 22-year-old has closed growth plates, and his pain is entirely at the inferior pole of the patella. That anatomical location is the absolute discriminator for patellar tendinopathy.
So how do we actually treat this 22-year-old athlete? The initial frontline management is usually fairly straightforward. A course of NSAIDs, anti-inflammatories, and a dedicated quadriceps stretching program. But what happens when that conservative protocol entirely fails? What is the definitive evidence-based physical treatment?
The definitive gold standard physical treatment is eccentric training. Eccentric training.
I really want to break down the cellular biology of why that specific type of training works, because it requires unlearning some deeply ingrained, outdated medical terminology. We used to universally call this condition patellar tendinitis.
And that word is a massive historical misnomer that misled treatment for decades.
How so?
The suffix itis implies active acute inflammation. But when we take biopsies of these painful tendons and look at them under an electron microscope, we do not see white blood cells. We don't see inflammatory macrophages.
So what do we see?
What we actually see is a failed healing response. We see mucoid degeneration. The type 1 collagen fibers, which should be lined perfectly straight and parallel like a dense bundle of steel suspension cables, are highly disorganized, tangled, fragmented, and mechanically weak.
So it's not a fire of inflammation. It's a structural architectural failure of the collagen lattice itself.
Exactly.
Which perfectly explains why eccentric loading works on a cellular level. Eccentric loading means the muscle and tendon are actively lengthening while under heavy mechanical tension, like slowly, agonizingly lowering a heavy weight rather than lifting it.
Precisely. Lengthening under tension creates massive shear forces within the tendon. This highly specific mechanical force stimulates the fibroblasts, the biological cells that manufacture and maintain tendon tissue, to undergo mechanotransduction.
Okay, big word, mechanotransduction.
It just means the physical stretch signals the cells to break down the disorganized matrix and synthesize new, healthy collagen. It literally forces the tangled, chaotic web of fibers to biologically realign themselves along the natural line of stress.
Wow.
You aren't resting the tendon to calm down a non-existent inflammation. You are aggressively, actively loading it to force structural cellular reorganization.
That is fascinating. The mechanical load is the medicine. Now let's move from a sick, painful tendon to a catastrophic, explosive failure of a tendon. Quadriceps tendon rupture.
Big one.
This is when the massive tendon above the kneecap snaps completely, detaching the muscle from the bone. I remember a board question that always trips candidates up regarding systemic risk factors. I think sickle cell was the exception, but I never fully understood why the pathology excludes it.
It is a brilliant question that tests your understanding of tissue-specific pathology. The classic board question asks which of the following is not a risk factor for spontaneous quadriceps tendon rupture: chronic renal failure, diabetes mellitus, rheumatoid arthritis, sickle cell disease, or hyperparathyroidism.
And the answer?
And the definitive answer is sickle cell disease. Sickle cell disease is not a risk factor for spontaneous tendon rupture.
To understand why it's the exception, we need a unifying theory of what the actual culprits are doing to the body. Let's look at the true risk factors on that list: chronic renal failure, diabetes, rheumatoid arthritis, hyperparathyroidism. Along with systemic or local corticosteroids, these are the classic culprits that cause tendons to snap. What do they all have in common biochemically?
They all systemically, biologically degrade collagen quality or severely weaken the transitional zone where the tendon fibers physically weave into the bone.
Okay.
Uremia from chronic renal failure, advanced glycation end products from high blood sugar and diabetes, chronic destructive inflammatory arthropathy from RA, calcium and phosphate derangements leaching from hyperparathyroidism. They all fundamentally alter the microscopic structural integrity of collagen. They turn a thick, strong biological cable into a frayed, brittle, disorganized one.
But sickle cell disease doesn't affect the collagen matrix.
No, it does not. Sickle cell disease causes red blood cells to physically deform and sickle, which microscopically clogs small capillary blood vessels, leading to massive bone infarction and a vascular osteonecrosis.
Oh, it affects the bone.
Exactly. It causes the hard mineralized bone to die from lack of oxygen. It is fundamentally a bone disease, not a soft tissue collagen disease. It destroys the architecture of the marrow and the cortex, not the tensile strength of the tendon itself. It might be the right patient demographic for joint pain, but it's the entirely wrong tissue pathology for a tendon rupture.
We mentioned corticosteroids as a massive risk factor for collagen degradation. Does the clinical warning about steroid injections really matter that much in practical day-to-day sports medicine clinic?
It matters more than almost anything else we've discussed today. I have a scar story about this. It routinely produces some of the most tragic clinical pictures in sports medicine.
Tell me.
Picture a highly competitive, semi-professional athlete. He has been battling excruciating inferior patellar pain for 6 months. He's tried some unsupervised physical therapy, and it hasn't worked. He is financially and emotionally desperate. The championship season starts in exactly 3 weeks. 3 weeks. He comes to a sports doctor looking for a magical quick fix.
And a localized corticosteroid injection is viewed by many as the ultimate quick fix for joint pain.
It is. The doctor draws up the syringe and injects a potent corticosteroid right into the sheath around the patellar tendon. And here is the profound tragedy of the intervention. It works beautifully.
Really?
Yes. For 3 weeks, the athlete feels absolutely zero pain. The steroid forcefully shuts down the local nerve pain receptors and clears out any surrounding reactive fluid. The athlete feels entirely cured and invincible.
But the underlying mechanically tangled, disorganized collagen we talked about hasn't been fixed at all.
Worse than simply not being fixed, the potent steroid has actively, aggressively inhibited collagen synthesis at a cellular level. It has biochemically weakened the tendon's structural lattice while simultaneously removing the pain, which is the body's only protective alarm bell.
Oh.
So, mid-season, feeling no pain, the athlete goes up for a massive explosive jump. He lands hard. The enormous eccentric force of the landing, multiplying his body weight by a factor of 10, hits a tendon that is structurally dissolved.
And it snaps.
The weakened collagen entirely ruptures. The massive quadriceps muscle recoils up the thigh like a snapped rubber band. The patella rides high. The entire extensor mechanism is physically destroyed, and the athlete's career ends on the spot on the court.
The injection worked. It successfully took away the pain, giving the athlete total psychological permission to maximally load a tissue that the medicine itself had actively biochemically weakened. That is a chilling paradox.
It is the absolute definition of a clinical trap. You fix the symptom and destroy the system, which gives us the distilled summary for this segment. Jumper's knee hurts at the inferior pole. It's a structural collagen failure, not an inflammation. Eccentric loading is the cellular treatment, and scleroid is the chemical that ruptures it, and sickle cell is a bone disease, not a tendon one.
Okay, let me pull out my FRCS flashcards.
Right.
I need to run through a high-pressure board exam lightning round simulation to make sure I have the absolute gold standard answers locked in for every critical metric we've covered today. Total precision required. Ready.
I am ready. Let's run the board simulation.
1. At what exact degree of flexion does the patella geometrically engage the trochlea?
15 to 20 degrees of flexion.
15 to 20 degrees. 2. What is the primary passive biological stabilizer against lateral patellar dislocation?
The medial patellofemoral ligament, the MPFL.
3. What is the primary dynamic muscular stabilizer?
The vastus medialis obliquus, the VMO.
4. What mathematical share of the restraining force does the MPFL provide?
50 to 60%.
50 to 60%. 5. Which specific fascial layer of the medial knee contains the MPFL?
The second layer.
6. Where is the exact anatomical, tactile, femoral origin of the MPFL?
Distal and just anterior to the adductor tubercle.
7. What is the precise radiographic landmark for drilling that femoral tunnel?
Schottle's point, perfectly identified on a true lateral radiograph.
8. What is the classic MRI triad immediately following an acute patellar dislocation?
A medial patellar facet chondral injury, a lateral femoral condyle bone bruise, and an MPFL tear.
9. When exactly does the devastating chondral damage actually occur?
During the violent relocation event, not the initial dislocation.
10. What is the statistical redislocation rate after conservative, non-operative treatment?
15 to 45%.
15 to 45%. 11. Name the 5 anatomical and demographic risk factors for that recurrence.
Young age, skeletal immaturity, trochlear dysplasia, patella alta, and an increased TTTG distance.
12. The Fulkerson anteromedialisation of the tibial tubercle is specifically indicated for which exact cartilage lesions?
Distal and lateral lesions.
13. And it is absolutely strictly contraindicated for what?
Proximal, medial, and diffuse arthritic lesions.
14. Internal rotation of the tibial component in an arthroplasty does what to the mechanical Q angle?
It mathematically increases it by laterally displacing the native tubercle.
15. What is the absolute worst physical position for cementing the plastic patellar button?
Lateral placement.
16. Which specific blood vessel must survive a lateral retinacular release at all costs?
The superior lateral genicular artery.
17. And what is the catastrophic biological consequence if it is destroyed along with the other blood supplies?
Complete patellar osteonecrosis.
18. Where exactly anatomically does jumper's knee hurt upon palpation?
Point tenderness directly at the inferior pole of the patella.
19. What is the definitive cellular level treatment of choice for chronic patellar tendinopathy?
Eccentric mechanical training.
20. Why must a clinician never use a localized steroid injection for this condition?
Because it biochemically weakens the collagen and risks spontaneous tendon rupture.
21. Which of the following systemic diseases is not a risk factor for quadriceps tendon rupture? Renal failure, diabetes, rheumatoid arthritis, sickle cell, or hyperparathyroidism?
Sickle cell disease.
22. Name the actual validated systemic risk factors that degrade collagen.
Chronic renal failure, diabetes mellitus, rheumatoid arthritis, hyperparathyroidism, connective tissue diseases, and chronic corticosteroid use.
Fantastic. That solidifies the entire structural and pathological map of the extensor mechanism. But I noticed as we walked through the geometry, we accidentally touched quite heavily on the mechanics of knee replacements today. We drifted significantly into arthroplasty territory.
We organically ended up there because the patellofemoral joint simply doesn't respect the artificial boundary of a knee replacement. A component rotation error is a patellar tracking problem that just happens to be caused by a metal tibial tray. But yes, next time, the deep dive is going fully exclusively into the total knee arthroplasty.
The total knee, what kind of biomechanical complexities can we expect to unpack?
It will be 20 intense questions. 20 questions, and it covers the absolute densest, most mechanically complex single topics left in the surgical curriculum. We are talking about balancing flexion gaps, balancing extension gaps, component rotation geometry, precise collateral ligament releases, implant kinematics, polyethylene wear rates, and catastrophic motor failure complications.
Give me the hook. Give me the mental puzzle I need to be trying to solve in my head before we start the next deep dive.
Here is the absolute classic puzzle. It's the one high-stakes scenario every surgical fellow gets asked about, and half of them get completely wrong under the pressure of the operating room.
I'm ready.
You are in the OR. You have made all your initial bone cuts for the knee replacement. You put the trial components in and test the joint. The knee is perfectly balanced, stable, and correct when the leg is straight in full extension. But it is way, way too tight when you try to physically bend it into flexion. The flexion gap is too tight.
Okay, tight flexion.
If you take the saw and cut more bone off the top of the tibia to make room in flexion, what mathematically happens to your perfectly balanced extension gap?
Well, the flat tibial bone cut affects both spatial planes. So if you cut more bone off the tibia to loosen the tight flexion gap, your perfect extension gap gets looser too. You completely ruin it.
Exactly right. You surgically fix one gap and completely inherently break the other. So what do you do with your hands? The correct answer isn't a bone cut at all. It is a highly specific component change.
Which component?
That is the cliffhanger. Next time, we will build the entire mathematical flexion extension balancing table from absolute scratch.
Amazing. Well, I want to leave everyone with a final provocative thought today to mull over. I want you to reconsider the profound tragedy of the scar story we discussed earlier. The athlete whose tendons snapped after a simple, well-intentioned steroid injection.
It's a tough one to think about.
It really is. We so often conceptually think of our joints and our tendons as inert mechanical cables and pulleys. We map them out like parts of an engine, just physical levers moving solid bone across a hinge, but they are emphatically not inert. They are living, breathing, highly reactive biochemical ecosystems. A localized injection of a chemical designed to simply silence a neurological alarm bell to turn off the pain can silently, invisibly dissolve the structural integrity of the biological cable itself at a microscopic cellular level. It forces us to ask a difficult structural question about how we practice. In modern medicine, when we relentlessly chase the immediate elimination of a symptom, how often does fixing that symptom chemically guarantee the catastrophic destruction of the entire mechanical system? Module 8.
Bring the saw.